Hello, good afternoon, everyone. Welcome to the Cottage Center for Orthopedics Meet the Doctor, featuring Dr. Rivka Lomedico, an orthopedic surgeon affiliated with Cottage Health. I'm Christina Cortez, the Public Relations Manager for Cottage Health, and I just wanted to thank you all for being here with us today. Before we get started, I'd like to review a couple of housekeeping items to optimize your experience during this webinar. At the conclusion of this presentation, we will host a brief question and answer session. So please be sure to use the Q&A button at the bottom of your screen to ask your questions. Also, this presentation is being recorded, so you will receive an email within the next week with a link to view the presentation and the PowerPoint slides. Now it's my pleasure to introduce our presenter, Dr. Rivka Lomedico. Dr. Lomedico is a fellowship-trained orthopedic surgeon and spine specialist at Alta Orthopedics, located in Santa Barbara, Santa Maria, and Solvang, California. Dr. Lomedico understands that the journey to seeking a spine consultation can be challenging for patients. She aims to provide compassionate, patient-centered care while offering a non-operative, minimally invasive, and traditional surgical treatments for all spine disorders. Dr. Lomedico is a Southern California native and a recent graduate of the Harvard Medical School Spine Surgery Fellowship Program in Boston and of the NYU Orthopedic Surgery Program in New York. So without further ado, please join me in welcoming Dr. Lomedico.
Thank you so much. I really appreciate this opportunity to be here today and to be able to meet everyone here. I'm so impressed with the Cottage team for putting this together. And again, my name is Dr. Lomedico. I'm an orthopedic surgeon, and I'm going to talk to you guys about orthopedics and osteoporosis, how to optimize your bone health. So I don't have any disclosures relevant to this talk, but I will have to admit that I'm kind of obsessed with bone health optimization and making sure that patients who have orthopedic issues focus on their bone health as a priority. So in terms of an overview, we'll kind of talk about my background a little bit. We'll talk about why would an orthopedic surgeon be interested in osteoporosis? What is osteoporosis? How does it impact orthopedics? Who's at risk for it? How do we treat it and how do we prevent it? Also, what is the regenerative bone health component of osteoporosis? And what else we can look out for on the future in terms of future perspectives? So a little bit about me, as she was just saying, I am from Southern California originally, from the San Fernando Valley. I went to undergrad at Davidson College, which is a really small liberal arts school in North Carolina. There I studied psychology, and that was my major, and I minored in Chinese. After I completed that, I went on to complete my pre-medical coursework at the Harvard Extension School in Boston. After that, I went on to medical school at Vanderbilt. At Vanderbilt, I got to learn a lot about basic science. In addition to pursuing orthopedics, I got to work in a lab with a man named Dr. Jonathan Schenecker and got to really learn a lot more about bone biology. I then did my orthopedic surgery residency at NYU. That was 6 years of orthopedics. The 5 years were really focused on surgery. So I operated all over the body, doing total joint replacements, hips, knees, shoulders, doing pediatric surgeries, spine surgeries, foot and ankle, trauma surgeries. So really everything in orthopedics. And then I spent 1 year in a basic science lab at NYU, where I did do some clinical, some randomized clinical trials, but I also did basic science research, so working with animals to kind of understand bone biology better and to see what kind of things that we can do to augment it and make it better. And I'll talk a little bit about my research later on in this discussion. After that, I went on to spine surgery fellowship at Harvard. And the spine surgery fellowship was 1 year dedicated to intensive mastery of spine surgery and spine disorders. I just moved from Boston to beautiful Central Coast in Santa Barbara last year, and I have to say I love being here. Everyone's so friendly and lovely. I work at Alta Orthopedics, and we have locations in Santa Barbara, Solvang, and Santa Maria. So you can kind of find me in the lower part of the Central Coast taking care of patients. What does my practice look like? Well, mostly it's spine, so cervical, thoracic, and lumbar, which are the neck, the middle of the back, and the low back. I do surgeries all over the body in those areas, front and back. This image here you're seeing is of a lumbar spine, a little person with a disc herniation here, this red thing can cause pain, sciatica running down the leg. So I can take out those disc herniations. That's called a decompression. I do disc replacements. I do fusion surgery. So this imaging that you're seeing here on the right is a person who has a spine that is a bit dysregulated because there's some instability. The bones are not stable, and this one bone here is shifted forward compared to the other one. So this person would get a spine fusion. I also do minimally invasive and endoscopic spine surgery. So here's a picture of me in my spine surgery fellowship operating. And endoscopic surgery is surgery where you have a very tiny, tiny incision, sometimes about the size of the eraser of a pencil. And then I also do complex deformity cases. So fixing people who have or are falling forward with kyphosis. I can correct their deformities and bring them back to normal alignment. So really kind of everything in spine world. So why osteoporosis, especially if I'm talking about all the surgeries that I do in my life? Well, again, this goes back to my early training at Vanderbilt. I was in a lab where we looked at skeletal injuries. So if you had a fall and you were immobilized for a while, the development of osteoporosis after that, but also burns, because burns can actually cause osteoporosis as well too. So kind of understanding the foundations of some of these things. And then while I was in residency again at NYU, I did more research in osteoporosis, animal models, and also using some human basic science models as well to evaluate it further. So it's always just been an interest of mine. How can I make my patient's bone health better? Because I know that surgery doesn't make the bones better, as it fixes problems, but how do we make those foundations of bones stronger? So here's a picture that you can see a person who has some spinal hardware in. We know that in the world of spine, if a person has osteoporosis, if we put in rods and screws to stabilize their spines, to bring them back into alignment, it can actually pull out and fall out of the bones if the bones are too weak. So osteoporosis really does affect about 20% of patients undergoing spine surgery, so it's quite important. It also affects about 50% of all women and 20% of men. And there's over 2 million people who sustain osteoporotic fractures annually in the US. That's a huge number. The American Orthopedic Association has really developed a program that's called Own the Bone. It's to encourage orthopedic surgeons to be more focused on fragility fractures and fragility fracture prevention. Because the reality is that having over 2 million fragility fractures a year is a huge number. If you have a hip fracture, there is a 1 in 3 chance, so about 30% chance that you'll die within a year. It's like a heart attack for your musculoskeletal system. It's a sign of fragility, not just of the bones, but the whole body. This number is greater than the number of heart attacks, stroke, and breast cancers combined. So it's a really big problem. It's becoming an epidemic, and it's really not treated. So here is a picture of someone who has a hip fracture. The arrow is pointing to an area where the top of the hip bone or the femoral head is broken off. And in addition to doing spine surgery, I still take general trauma calls. So you can find me if you have a hip fracture, I might be fixing it at Cottage Hospital. And so I do care about, general orthopedics as well too. And to me, I'd rather, instead of fixing the fracture, I'd rather fix your bones and improve your bone quality so you never even have a fracture in the first place. I want my patients to not have orthopedic problems that need surgery. I'd rather optimize them beforehand. I like to focus on the sort of preventable orthopedic disease, which is kind of odd coming from a surgeon because I do enjoy operating. So what is osteoporosis? This image here on the left shows a picture of a normal female who her bones are, she's standing upright, she has strong bones, she's about 40 years old. It's in this kind of green area where the bones are healthy, the cell turnover is normal. If she was to fall onto her bottom, she might just get a bruise. This woman who's now 60, she's just aged a bit. She has a slightly reduced bone mass, so she probably has osteopenia. So she's shrinking somewhat, and the bones themselves, they have more holes in it, so less density. And so she may fall and break a hip or might not. And the person on the far right has osteoporosis. So as you can see, it's really, really full of holes. There's not much density. And if she falls and now she's bending over, her body's more frail, she'll probably break her hip just from a simple slip and fall, or sometimes even just sitting down hard or the wrong way. This picture here shows the spine. It shows the thoracic spine or the middle of the back from the side. A normal bone should be shaped like a square, kind of like this one here, or even this one here, just like a square. As you can see, this one is not really shaped like a square. It's more like a bow tie. and it's all white inside. So this reflects someone who actually had a vertebral compression fracture. That's when they do something and have an injury inside of their spine. My most recent patient who had this kind of injury actually sustained it from just lifting up a window to get some fresh air. That action of lifting up caused her to break her spine and have a severe pain in her back with this sort of injury. So we're talking about minimal trauma causing really debilitatingly painful injury. What's the definition of osteoporosis? So looking here, we're looking at ranges. So the normal is what we call the T-score. We're looking at the normal range for an average 30-year-old is anywhere from -1 to about +4. And if you're below that, so below -1, anywhere from -1 to -2.5, you fall into the osteopenia category. So you have low bone density, but it's not so severe. You can do certain things to maybe bring yourself closer to that normal range or prevent getting into that really red range, which is osteoporosis. And osteoporosis is anything that's less than -2.5 as a T-score. So if you are going to the -2.5, that means you have osteoporosis. And really -3, you shouldn't even, very few people are in -4. That's like extreme osteoporosis. So who's responsible for managing this? If it's not really the orthopedic surgeon, who do patients see? Where's the first stop? So the primary care doctors are amazing. They take care of our whole body. When you see them, especially for an annual visit, they will look at a checklist of things that they want to make sure that you're checked off on to optimize you. They'll check your heart and lungs. They also care about your bones. And so they might send you to get a bone density just as a part of regular screening as you get older in age. What about endocrinologists and rheumatologists? Where do they come in? Well, they're really the experts on bone disorders, bone metabolism. Endocrinologists and rheumatologists, they can take care of patients who have what we call metabolic bone diseases, so have an actual disease of the bone that might be caused by some hormonal derangement. They can take care of people with autoimmune disease and also all sorts of things like rheumatoid arthritis. So they're really the experts of bone biology and managing it with medications. And so that's who you'd want to really see if you could. The problem is that there's a big wait time. Even when I was in Boston at some of the, some really great hospitals, patients there, if you had an injury and you wanted to get treatment and see an endocrinologist or rheumatologist, you'd be waiting 6 months to a year, especially if it wasn't something that was really urgent. So there was a long wait time. And I know that that's very similar here, unfortunately, in the Central Coast and kind of really throughout the country. There's not enough of these good doctors, and there's not enough primary care doctors to take care of this problem with the way it needs to be treated. What is a fracture liaison service, or FLS? So a fracture liaison service is a group of doctors or clinicians, usually based out of a hospital, who help to manage patients when they come in with a fracture. They'll get them started on a bone health medication and get their health optimized and kind of follow them as an outpatient or get them teed up to have the appropriate management as an outpatient. Well, what's wrong with this? Well, there's really just no guaranteed follow-up. Most hospitals do not actually have a fracture liaison service. And if they do, it might not be compatible with where the patient's actually coming from or going to. Maybe they live far away and they were just traveling through and had an injury. So patients really aren't getting the care that they need. What about the orthopedic consultant? Where do I come into the picture or any other orthopedic surgeons come in the picture? Well, they'll call us, Mr. Smith has a hip fracture. We'll see you, we'll fix the problem, and we'll tell you usually that you have osteoporosis. If you didn't know, now you should know that, because you fell and, just landed on a chair and sat down hard, you have this fracture, it means you have osteoporosis. And we'll usually tell you, see your primary care doctor or go see an endocrinologist, go see a rheumatologist, but we really don't tend to get too involved in the prescribing of medications to manage this. So what about the bone health priorities? Like, what do these different people that are involved in the system actually care about? Well, the primary care doctor, when they're going through their checklist, they really don't want you to have fractures because they know that that's bad. When you have a hip fracture, you can end up passing away pretty quickly. So they want to avoid that. Endocrinologists and rheumatologists also know that. And so when you come to them with your standard osteoporosis, they want to reduce your fracture risk. That's what they care about too. And what about the orthopedic consultant? Well, of course, we don't want lots of people to have fractures, especially older in age, but I would argue that the orthopedic surgeon has more skin in the game or more things at stake, especially if we're taking care of you and you've had a fracture, because we want you to do well. we want to improve surgical outcomes. And even if you haven't had a fracture and you just have osteoporosis, we want our surgeries to go well. We want you to heal quickly. We want whatever we're doing to take and the bones to unite. We also want your osteoarthritis to get better. So when you come to our clinics and we give you injections into your knee or your hip, and we give you steroids, we might give you PRP or other sort of treatments, we want to get rid of your arthritis. We want your bone pain to go away. And we also want to improve your tendon healing. We care about your whole musculoskeletal system because we work with it every day. We want the tissue that we're working with to be healthy. So wouldn't you know that osteoporosis actually worsens surgical outcomes? Many, many, many studies over time have shown, especially in the world of total joint replacement. So if you know anybody who's getting a shoulder, hip, or knee replacement, or who's had one, or who's planning on getting one, it's actually, if you have osteoporosis, you have an increased risk of fracture during surgery. That means when the surgeon is putting in the implants, your bones can split apart if they're weak. You also have an increased risk of hardware loosening. That means the hardware that's put in can actually begin to fall out over time because the bones won't heal as fast as they need to. And there's also a high risk of revision surgery. So that means that you're more likely to have that implant changed out or something changed because of an issue with the surgery afterwards. So that's pretty scary. So since we've known this for such a long time, what's really being done about it? Well, unfortunately, not too much. This study out of New York, so from Cornell and HSS, they looked at patients who were undergoing a total joint arthroplasty, so a total joint replacement, and the patients who had osteoporosis. They found that in patients who had osteoporosis, who should have been treated with osteoporosis medication, only 20% of patients were getting treated. That means 80% of people who had osteoporosis and were getting orthopedic surgery did not get any treatment to optimize their bones before they went in for surgery. That meant just kind of accepting the risk as though it's just, a given. Mr. Smith or Miss Smith, you just have osteoporosis. We're going to do your surgery anyways. And we're aware versus let's get it better. Let's make it better so your surgery goes better. What about spine, which is kind of more my world? Well, the disease itself, spine disease, is worsened by osteoporosis. When you have bones that are soft like butter, they move, they shift. You can end up with the bones that shift, which is called spondylolisthesis, bones that slide out of place. What about surgery? Well, just like that picture I showed you before, when we put in rods and screws to stabilize those shifting bones, they won't stay in. It's like putting a big screw into drywall. It can pull right out. Things subside, so the bones can collapse around each other. There can be fractures during surgery. Other levels in your body can begin to have deformity because the bones are so soft, they continue to move. The bones can break down, and then you can actually have delayed healing as well. So the bones might not unite the way that we want them to. And what about sports medicine? I know a lot of sports medicine people might think, oh, it's just tendons or soft tissue. It's different. Well, it's not actually different. Unfortunately, because there is a connection between our muscles, tendons, and bones, when you go to get your rotator cuff repaired, if you have osteoporosis, you're more likely to actually end up with a complication and having that cuff repair fail. So you're more likely to fail a rotator cuff, repair. That's pretty significant. And beyond that, if you have osteoporosis, you're actually more likely to even get a rotator cuff tear. So it's beyond fractures. This goes beyond, doing joint replacements or spine surgery. It even comes down to tendons and are more likely to get injuries that can even include knee, meniscal tears, other things. When we have poor bones, our whole body system becomes dysregulated. Our whole musculoskeletal system becomes dysregulated. So who is at risk? Really, women are at risk for this more than men, and that has to do with menopause. When we go through menopause, our body becomes depleted of essential hormones, and that gives us our increased risk of osteoporosis. Age is an important factor as well, too. I believe that around 50 to 65 years of age is when, especially for women, we should begin to think about our bone health and maybe go in for a baseline test to get a check and see where you're at. So body size is important. Smaller, more slender people just carry less weight on their bodies, and weight bearing is actually good for our bones. So if you're very, very small or underweight, low body mass, you're at a higher risk for having this problem. Caucasian race, unfortunately, as well, is more predisposed to having osteoporosis. Family history is important. So if you have a family member, like say you knew your mom had a hip fracture late in life, then you're more likely to have one too, and you're more likely to have osteoporosis. So someone in your close family who has osteoporosis is a risk factor. Medical history cannot be overlooked. So being on long-term steroids, anti-seizure medications, some cancer medications, mostly the aromatase inhibitors, like things for breast cancer, protein pump inhibitors, which are medications for reflux. SSRIs are medications for depression, certain medications for diabetes, endocrine disease as well, rheumatoid arthritis, hormones. The list is quite long of medical conditions that can actually lead to you have an increased risk of osteoporosis. What about lifestyle? Diet, again, is very important. So if you are doing a lot of fad dieting, or you did a lot of fad dieting in your younger life, restrictive eating for particular reasons, that actually can weaken your bones. So being inactive is a risk factor. So if you're the kind of couch potato, you like to sit there and watch TV and maybe read a book or knit and walk occasionally, maybe once or a couple times a week, and that's your exercise, that really would fall in the category of inactive, and that increases your risk of having osteoporosis. Heavy alcohol use, so anything more than 3 drinks a day on a regular basis would be considered a risk factor for developing osteoporosis, and smoking as well too. So how do we look at this? We do what's called a DEXA scan, or a bone density. And there's other different metrics out there, but usually the DEXA scan is kind of our main gold standard across the country. It's similar to getting an X-ray or a CT scan. It's a picture of your bones. They usually get a picture of either your spine, your hip, or your distal radius, which is the wrist bone, the bottom of your wrist bone. And they get a quick picture of it to tell what the bone density is. And then from there, they calculate your score. And it's the lowest score of any of those areas. The distal radius, or the wrist, is actually the ones that's most sensitive. So if you think you have osteoporosis, and you're really concerned, you want to check to see what body parts they're scanning and which one on your results has the lowest one. That is actually your diagnosis for osteoporosis right there. So osteopenia, say, you don't have osteoporosis, but you have osteopenia. You're at that less than -1. What can you do? How can you improve? So the first thing is lifestyle, weight-bearing exercise. Walking to me is a basic essential function of living. If you're not walking every day, then you're not doing anything for your whole body. Walking is a basic core important thing to do, but it's not weight-bearing exercise that's going to take you from being osteoporotic back to being osteopenic or improve your bone density. You have to do things that actually put some force on your bones. That's more than just walking occasionally. So weight-bearing exercise, that can actually be lifting weights. You can go to the gym, you can go to the YMCA. If you don't know what to do, you can go to a class, you can see a physical therapist, you can ask your doctor to prescribe that for you, and they can. And physical therapists can get you started moving. And then, what do you take in terms of supplements and medications? So you can take vitamin D3, you can take about 5,000 international units a day, or whatever comes in your typical vitamin and supplement bottle. Diet. What kind of diet is good for people who have osteopenia and don't want to get to osteoporosis? So calcium is just a basic fundamental building block of bones. It's important. Calcium, you can find that in a lot of different dairy products, so eggs, cheese, cottage cheese, milk. You can also find it in fortified plant-based alternatives for people who have altered diets and lifestyles. Vitamin D is also very important. It actually helps your body to absorb calcium, so it's quite important that you get that in your diet as well too. Protein is a fundamental building block for bone and bone tissue. So protein, of course, you can get it from meats and fishes, but you can also get it from different beans and grains. Magnesium is another essential criteria. It helps bone health by aiding in calcium absorption, and that helps with bone formation. Vitamin K is also important. It actually helps to regulate the levels of calcium in your body. So at any given time, the level of calcium is enough so that your bone can have enough calcium for its regular metabolism and turnover. And then again, maintaining that healthy weight, and that is a healthy weight. You don't want to be too underweight, and you don't want to be too overweight. So obesity with osteoporosis is probably one of the worst combinations, because if you have really thin bones and you're very overweight, if you break those bones, it's hard to mobilize, it's hard to rehab, and it's hard to get better afterwards. And you want to moderate your alcohol intake as well too. So that's important. Like I said, anything more than 3 drinks a day on a regular basis is way too much alcohol, and that can really have an impact on your bones. So what are the treatment options? So there's a lot of medications I'm going to mention here, but I'm going to kind of put them into categories. So anti-resorptive medications, that includes bisphosphonates. Most people have heard of bisphosphonates or are on a bisphosphonate. So Fosmax, Actonel, Boniva, Reclass. So there's just some brand names. Other names are alendronate, risedronate, ibandronate, or zoledronic acid. They're just different types of bisphosphonates that are some of the most commonly prescribed for osteoporosis. Denosumab is Prolia, and that's now something that's very commonly prescribed as well too. Raloxifene is a medication that works through hormone receptors. Calcitonin is one that's typically prescribed for patients who might have some pain after, for example, having a vertebral compression fracture, but it's actually not that frequently used. And then anabolic medications. It's a whole different category of medication. So anabolic medications include teriparatide, abaloparatide, and romosozumab. So Forteo, Tymlos, and Avinity are those brand names. And those are medications that actually build up the bone. So how do anti-resorptive medications work? It just changes the balance. If you think about your body as being a wall of bricks, it changes the amount of bones that are decaying and old and have to get replaced at any given time. So bisphosphonates are some of the original drugs. The etridronate was initially synthesized over 100 years ago. Over 100 years ago. Not much in the pharmacology book that we're using these days has medications that are that old. And in fact, they've been in regular clinical use for about the past 50 years. They're usually in a pill form, they're cheap and easy, and they work. If you again think about your body being a wall of bricks, you have these old bricks that are getting replaced because they're decaying and new bricks that are getting laid down. And over time, the bisphosphonates reduce how fast those old bricks decay. So that way the new ones that are getting laid down kind of have time to catch up. It doesn't speed up the bones that are getting laid down, but it just slows down the decay of the older ones. So it reduces the osteoclasts, which are those bone breakdown cells. It typically leads to an increased amount of bone you have on the outer shell. And alendronate and risedronate are some of the ones that are most commonly given, and the evidence does show that they help to prevent spine and non-vertebral fractures. So what are the downsides of bisphosphonates? So osteonecrosis is a downside. That's when people oftentimes have it in the jaw and it can decay from being on a bisphosphonate. Atypical fractures, which are what you see in this picture here. And an atypical fracture occurs because the bones sometimes get so thick on the outside and they're still so thin on the inside so that they break pretty easily, they become actually brittle. And I've taken care of my fair share and had to fix many, many of these atypical fractures from patients typically on Fosmax for a very, very long time. You can't be on those medications for forever. So if you've been on them for over 5 years or more, you should really talk to your doctor about what to do next. They're typically not recommended if you have reflux. So if you have acid reflux, you usually can't take bisphosphonates, and they're not ideal, or it's kind of controversial if you should be really on these medications when you're having spine surgery, because it's not good for fusion, it's not good for bone healing, and if you're undergoing dental work. So it's a little controversial, but that's typically tends to be the things. And then denosumab or Prolia is a really effective antibody. And similar, again, it reduces your osteoclast from maturing and reduces that bone resorption. So if you again think of your body like a wall of bricks, it stops the wrecking ball from coming to break it down. So it gives time for those bone building cells to continue to line the walls of your bone. And there are some good studies that show that a combination of Prolia or denosumab with some other anabolic medications together can actually lead to a better improvement in your bone density than just one of the medications by themselves. So anabolic bone medications sounds like you can imagine someone weightlifting in a gym, taking steroids, building up their muscles to get really, really bulky. And I like to think of my older geriatric patients getting their bones strong when they're on these medications. So really taking it from being weak to strong in a very powerful way. So some of the first class here are parathyroid hormone-based medications, and those include Tymlos and Forteo, or Tymlos and Forteo, so teriparatide and abaloparatide, and they actually work by actually stopping the bone blasting cells, or the ones that build bone, so osteoblasts, the ones that line the walls, they actually stop them from dying. So it's imagine that you have these workers who want them to put your roof on and they keep taking breaks. It stops them from dying, so they keep going and they keep going. So they build more bone than they otherwise would have. So it actually builds the bones faster, makes them stronger, even quicker than the other medications do. So benefits of this are in the spine world, it reduces the rate of complications and it increases the likelihood that you're going to fuse. it makes your fractures heal faster. So if you have a fracture and you get on like teriparatide afterwards, your fracture is going to heal faster. Your pain is actually going to go away faster, and your mobility after a fracture or after having surgery is going to be better. So if you want to walk, you're going to be walking faster if you've been on one of these medications. And there's a lot of good research to show that. And then this other medication, Navinity, also known as romosozumab, is based on is an anti-sclerostin-based medication and inhibits sclerostin. So again, it's an anabolic bone builder. So it makes those worker bone builders continue to work and build more. And so it builds up the bone and it makes them particularly stronger. And one of the really amazing distinguishing features of this medication is that you have a really rapid increase in your bone mineral density compared to bisphosphonates and teriparatide, and that happens earlier. So if your bones are getting broken down very quickly and you're kind of in a state of a breakdown crisis, Avinity tends to be one that gets to a good state in your bloodstream a lot faster than some of the others. So it's really good, and it has good clinical evidence behind how strong it can make your bones be. What are the downsides of anabolics? Because it sounds overall almost like a wonder drug in some ways. Well, they're really costly. It costs a lot of money, thousands and thousands of dollars, because they are the best in class and they're newer. They're not hundreds of years old. And they're all injections. So the parathyroid-based medications, those are injections you give yourself every day. Patients may initially, have a bit of a shock at that, but the needle is quite thin. It's thinner than an eyelash. And, when you put it into the skin, you can put it into a fold of skin. Everyone has a little bit of roll or a wrinkle near their belly. You can't even feel it. And I've given patients these injections in clinic and they don't even notice the needle going in at all. So it's not painful whatsoever. And patients can pretty reliably do this to themselves. Avinity is one that's nice because it's just once a month, but you have to go see your doctor or go to the hospital to get an injection for that. So just once a month, a shot, and you're not on these drugs forever. It's just a short period of time to build your bones up. So we've kind of talked about these medications. We know that they're all meant to build up your bones. So you can get on any of them, really, right? Well, the problem is there's infrequent treatment. So this study came out of MGH, which is a hospital, and the Brigham, which are hospitals based in Boston. And they looked at the secular trends. So what is going on across the nation from people on a US commercial insurance database. So people who have commercial insurance from 2009 to 2020, what are they getting for their osteoporosis? So overall, most people were getting alendronate and they were getting denosumab or zoledronic acid. So those were the most commonly prescribed medications over this time period from what they saw. But the bad news is, the real bad news is that unfortunately, they started out in their early bits of their studies. So 2009, they saw that after having a fracture, patients that had bone-directed therapy was about 15%. You'd want that to increase over time as people are becoming more aware. In fact, it actually went down. So towards the end of the study, so towards 2020, it went from 15%, which is pretty bad, to 8%, which is even worse. So it almost went down in half. So only 8% of people who went in and had a diagnosis of an osteoporotic fracture got treatment for their osteoporosis. That's pretty abysmal. So not only is it infrequent treatment, but it's inadequate treatment. And I guess inadequate, what would be adequate? So alendronate, again, it's been a mainstay. It's been used for 40 years or so. It's a medication that is one of the most commonly prescribed medications for osteoporosis. But we've had other medications that are better than alendronate for a long time. So Prolia has been out for a long time. So is teriparatide, and then the other medications that are anabolics that have been out for a long time, which have very clear evidence of being better than bisphosphonates. They aren't commonly prescribed. They're not prescribed nearly enough. And here's just a couple studies real quick. So the ARCH trial, it compared romosozumab or Avinity to alendronate, and it looked over a period of a year to see was there a difference in fractures if you were on a bisphosphonate versus Avinity. And there's a very clear winner. Romosozumab was far and ahead, a leader in preventing patients from having clinical fractures. That's anywhere in the body, really, things that were obvious, and major fractures as well, too. And then the Vero trial. So the Vero trial here is comparing teriparatide to risedronate. So again, an anabolic medication, this is a parathyroid-based one, to a bisphosphonate. And the red line shows teriparatide, black line shows risedronate, which is a bisphosphonate. And as the line goes up, that shows the rate of fractures. So very clearly at about 3 months, you can see the change where people who are getting the teriparatide, it starts to peter off in terms of their fracture risk. But the risedronate people, it continues to go up and increase to be about twice, if not more, over time, the number of fractures if you were getting that compared to teriparatide. So there's really no comparison. The anabolic medications are better for bone density. They're better for building your bone. And so for me, this here is really where the drum roll is. Can osteoporosis medication reverse arthritis? So forget actually having osteoporosis. Can some of these medications actually improve arthritis? And think, do you know anybody who has arthritic bones that can be in their knees, their hips, their shoulders, their hands, joints that hurt from arthritis? Well, studies have shown for over 10 years, especially in the basic science world, so studies of animals have shown that teriparatide has the ability to actually regenerate cartilage from the ground up. So they've done studies on animals where they've followed animals that have osteoporosis in their joints and treated them with doses of teriparatide and seen that the bone itself gets stronger, and that in and of itself changing the bone metabolism helps to change and regenerate the cartilage for these animals, which is pretty impressive. Now, leaning into the human world, there's studies that are ongoing right now, randomized controlled clinical trials where they're comparing teriparatide and seeing how it actually affects arthritis. And regardless of your osteoporosis, we already know that it makes your osteoporosis better. It can actually reduce joint pain from arthritis. It reduces the inflammation in the joints, and that's called synovitis. So it reduces inflammation in the joints, it reduces the pain people have, and it actually makes it so the joints are smoother, so they hurt less. And that's pretty amazing. Yeah, this one group out of New York is going to begin to publish some of their human studies soon. So that's something to look out for on the horizon as something that's really amazing potential therapy. And then my research. I've done, like I mentioned, in NYU, I spent a year doing research. I did clinical trials, which is studies with humans, and I also did animals work as well, too. And so in my human studies and animal studies, one of my big projects was actually looking at the effect of cannabidiol, which is the non-psychoactive component of cannabis, and its effect on the musculoskeletal system, because people use it. It's available widely everywhere. People use it in their drinks. They take it for mental health. They take it for inflammation, all sorts of reasons that they might have. But we do know in a lot of literature that it actually has an impact on our bone metabolism. So I wanted to explore that further because there's not a lot of good data on living tissue about how it affects us. So in the human study, in the human arm of my study, I actually took human stem cells. I took them from femoral heads that were discarded after a hip replacement. So when you get a hip replaced, they take away the old bone. And I used that old bone that they were going to throw in the garbage. And I harvested the stem cells from those bones and then treated them in increasing concentrations of CBD to see how the CBD would affect the human cells. I looked at the cell viability, so how healthy they were, how they grew, which is the proliferation. And I also looked at the osteogenic differentiation, which is essentially what kind of markers and genes do they express in terms of becoming bone. And I found that treating human stem cells with low concentrations of CBD actually increased their viability, the proliferation, and their osteogenic gene expression. So it actually had a really good impact on human stem cells. And then in my animal experiments, I had two arms. One of them was focused on a more of a medication-induced osteoporosis. So I induced osteoporosis in mice by treating them with fluoxetine, which is one of those medications for depression. And then I also gave some of those animals that were on the fluoxetine, I gave them CBD as well to see if it actually could stop them from getting osteoporosis. And I found that the good thing is that CBD had no impact on fracture healing in healthy mice, but it actually improved the bone mineral density in mice that were treated with fluoxetine. So that means that those mice didn't actually end up developing osteoporosis if they had CBD at the same time that they had their fluoxetine. And then my second experiment, this one was more in line with osteoporosis that's caused by menopause. So I had an ovarectomy model in animals, so did an ovarectomy to induce menopause, and which caused osteoporosis. And then I evaluated and treated them with CBD at the time that they also had their ovarectomy, and afterwards, also when they had an injury, to see how their bones healed, how their bone metabolism changed over time. And in brief, some of my findings were that treatment with CBD actually prevented the animals from having osteoporosis in the first place. So the animals that I did the ovarectomy on and I gave them CBD at the same time, they actually never ended up developing osteoporosis. Also, pre-treating them with this medication or the CBD prevented them from having a delay in healing. So typically people with osteoporosis have altered bone turnover and they don't heal bones as well sometimes. So this pre-treatment with CBD prevented that. But I did find some interesting things, which is that treating these animals with CBD at the time that they had their fracture just changed the quality of the fracture callus. And what can you really tell from these studies is that maybe CBD does have a positive effect on bone turnover, but we need to do human research. We need to find out what it really does to our bodies. So this is just what we call the beginning of possibly translational research to understand better how something that's so common can impact our bone system. So what is my osteoporosis protocol? And I do have a protocol, which is essentially looking at bones. And I'm happy to see patients who come in with all sorts of problems. They could have a spine problem, or they want to get their bone health optimized for other reason. I'll screen them. I will look at their hip, spine, and distal radius. I get labs. I know I'm running out of time, so I'm going to try to speed up here. And I make sure to document well. I want to look at all of your medical history. And I always start first with the anabolic medications because I want to go to the best rather than the oldest. I start with anabolic medications. And after that, if for some reason you're not eligible for them, then we'll start with the second line, which is denosumab and reclass. Anabolics are key. Again, you don't have to be on them forever, but over time, once we build your bones back up, we can stabilize it at that higher level with a couple doses of bisphosphonate or Prolia. And then we have to talk about falls because if you don't fall, then you won't break a bone. So fall prevention is important. You want to make sure you know what you're taking for medications, see a physical therapist, work on balance training, fall-proof your home. And then kind of take home points. Again, for me, the main ones are that osteoporosis can also cause tendon tears and it can make your surgeries become more complicated. So you want to avoid it and treat it if all possible. And that treating osteoporosis with anabolic medications may actually reverse arthritis and regenerate your cartilage. I think you guys kind of got some of the other ones, which are get screened. You can see me if you want to get a screening test. I'm happy to take care of you. And you want to communicate with your regular doctor as well, too. And again, focusing on anabolics as the main medications to treat. Thank you so much for your time. I appreciate it. I know there was hundreds of people who signed up for this talk, so I hope you guys learned something.
Thank you, Dr. Lomedico. That was a really informative presentation. You did a great job. We'd now like to move on to the question and answer session of this talk. We have quite a few questions that came through during your talk, so we'll do our best to get through as many of them as possible. Just as a reminder, if you haven't already, please put your questions in the Q&A box that's located at the bottom of your screen, and I'll read them off to Dr. Lomedico. So we have a lot of great questions. So our first question is from a participant who is asking, let's see, what advice would you give someone who has early arthritis and osteopenia? And how do you avoid osteoporosis and exercise with joint pain?
Yeah, that's a good question. It's like 3 questions in one. So if you have osteopenia, that just means that your bones aren't as strong as they should be. And if you already have arthritis, I know a lot of patients say, oh, well, how can I exercise? My joints hurt. So there's all different sorts of exercise you can do. It doesn't have to be running and putting a lot of weight on your bones, something that you find painful. You can do exercise in a pool, like aquatics. Yoga also counts, especially like power yoga, things that are going to involve lunges, squats, things that aren't necessary. It can be slow and measured. It doesn't have to be a repetitive type of pounding on the bones. And then the second part of the question, I think, was just focused on, what can you do to improve your bone health if you're in this category as a patient? And like I mentioned, diet is important. So you want to make sure you have a good holistic diet. And you can get screened. Make sure you get screened on a regular basis every 2 years if you fall into that category, because you don't want that number to slip even lower to a point where you need to start taking medication to treat it.
Great. For our next question is osteoporosis throughout the entire body's bone structure, or can it be isolated to a specific area?
So it's usually throughout the whole body, especially if it's caused by something. So there's different causes of osteoporosis. One of them, we call it senile osteoporosis, which is just osteoporosis of aging. There's hormonal, which is postmenopausal. There's osteoporosis that's caused by, for example, I mentioned burns or trauma. Some people have osteoporosis in a particular body part. So I see this a lot, especially in trauma surgery. So patients who have like an ankle fracture or a foot fracture might be told you can't bear any weight on your right leg for 3 months. So if you don't bear any weight on your right leg for 3 months, On the x-rays, you can get what's called disuse osteopenia. So over time, the bones get demineralized. And on the x-rays, you can see at the time of fracture, your bones actually looked healthy, but at 3 months after not putting weight on it, that one limb or a foot becomes almost like a ghost. The bones become really, really soft. So that's a risk factor. So it can definitely impact the whole body, or just one limb. And regardless of which one it is, getting on medications to treat it can impact and improve that kind of issue. But if you do have it from just being immobile in one limb, just using the limb and putting weight on the limb tends to help and can bring your bone density back to kind of where it should be.
Wow, that's really interesting. Thank you for answering that question for us. When taking Fosamax weekly to treat osteoporosis, how much calcium should one take?
That's a good question. So if you're taking Fosmax, I would say to start, you need to see how long have you been taking that medication, and what kind of side effects is it causing? Because you can't take Fosmax for 40 years without any issues. You have to probably change it at some point. Every medication has a limited amount of time that you can be on it. It's not like other medications you can take for your heart or something like that, which you can be on for your whole life. You probably have to change it. And usually whatever comes in your typical vitamin container, like a multivitamin, is usually enough. The Fosmax doesn't really change the amount that you need to have and maintain a normal bone health. You can just take your supplements and also just make sure you have a good diet. A good diet that has dairy, and also you can also take, if you're not eating dairy because of whatever reasons, you can do plant-based alternatives as well too that are fortified.
Okay, great. Where can one get a DEXA scan? And do you need an appointment with an orthopedic surgeon or a referral? How does one go about that?
So I guess going back to the beginning, the DEXA scan is it's like an X-ray or a CT scan. So you do have to have an order for it. It is a physician ordered test. Typically, primary care doctors are the ones that you see. I'm a little bit of an anomaly, and I know a couple other orthopedic surgeons maybe in the country. I'm talking about a handful in the country that would be interested and willing to take care of this problem. But usually orthopedic surgeons are not going to order a bone density unless they are really scared about something or worried. Usually primary care doctors, rheumatologists, or endocrinologists would be open to taking care of these issues. So, I mean, I'm also happy to take care of it, especially for like straightforward osteoporosis. If you have rheumatoid arthritis and immunologic disease or a more complicated picture, then usually seeing an endocrinologist or rheumatologist is what I would certainly recommend as well too. But for kind of straightforward osteoporosis or screening, or you want to get that sort of opinion, I do telehealth, so remote visits as well for this sort of problem. But your primary care doctor is going to be your go-to for that.
Great, thank you for that. And I think you touched upon this a little bit in your presentation, but how does Ehlers syndrome influence the bones?
Oh, Ehlers-Danlos. So I didn't really talk about that very much. So I would say that the effect of that on your bones in regards to osteoporosis, it's going to be something that you should speak, because everyone has that syndrome in different severities and degrees. And that kind of falls outside of the realm of what we call like senile osteoporosis or your typical osteoporosis. So your typical osteoporosis is, again, just caused by aging, inactivity, or hormonal imbalance. And so when you have these other disorders that come in, then everyone has a different level or degree that it can impact our bones. So it's something that you should definitely be talking about with your rheumatologist or your endocrinologist or your primary care doctor with regards to where you're at and your severity of disease.
Okay, great, thank you. Oh, this is a really good question. There's various types of calcium out there. So which one is absorbed best?
So the ones that are absorbed best are the ones that you take as regular food. So having a regular diet and eating a good, healthy diet is the best way to get all the nutrients that you need. Anything that you're taking that's been formulated in a capsule and things like that, they'll see everyone trying to sell you some sort of pill that's going to be the best pill. But, the dietary intake is really the best way to get in the things that you need.
Okay, well, speaking of dietary, we have two different questions. One is on what foods have magnesium in them, and another question is what foods have vitamin K in it.
So the good thing is that they tend to be a good overlap. Green leafy vegetables tend to have both. and bananas as well too. A lot of fruits do, but green leafy vegetables, grains, whole foods tend to have these ingredients. And unfortunately, in the world of fast and processed foods, a lot of things we think could be healthy really aren't and don't have anything green in them, don't have anything that's natural. So good green leafy vegetables, kales, hearty things tend to be the ones that have the best nutrients.
Great. And I think we didn't, I don't think we touched upon this one, but in regards to physical activity, how do you feel about weighted vests for
Weighted
exercise?
vests. Oh, weighted vests. Someone's going hardcore. So weighted vests. So, um, weighted vests are great. If you want, everyone has to find where they're at. Some people just need to actually get up off the couch as the first starter. Going to the gym is like the next step. Weighted vests are great because it actually adds more weight to your body, so then you are carrying more weight around. But that might be a little too much for some people. Some people go hiking with like what we call rucking, where you put extra weight and 30 pounds on your back and you can climb a mountain. So wherever you're at, if you're doing weighted vests to increase the weight that you're carrying on your body for a moment, that's definitely going to be good. That's going to help your overall musculoskeletal system. If you want to just go for a walk but with extra weight on, that's not a bad idea, to take it easy but also to increase the amount of weight you're carrying. That's a great idea.
Okay. And related to weight, how do you know the appropriate amount of weight that will help strengthen your bones without compressing your spine?
So if I'm not sure if that's related to wearing the weighted vest or
No, that's a separate question. So I
okay.
think it's just related.
So the amount of weight to just have on your body. So we look at BMI. It's not the best metric, but it's just like an estimate of like what your amount of fat or muscle or body tissue that you have that you're carrying relative to your height. And so you don't want to have a BMI, which stands for body mass index, that's low. So if you're like less than 18, less than 17 for your body mass index, you're beginning to enter into that lower bone density, lower weight ratio that can increase your risk for having a fracture, or increase your risk for having osteoporosis. And then having too much weight on. So anything when you're getting over the 30s in body mass index, now we're talking about things that are going to increase your risk for just other medical problems. So usually somewhere in the 20s, is acceptable, and that's are usually a reasonable amount of to have as a BMI, as a standard BMI.
Gotcha. We have several questions coming through about Evenity and the heart risks of taking Evenity, and if you have severe osteoporosis, and are you at high risk of a heart attack if you take Evenity?
So, unfortunately, there is not every medication is for everybody, which is why you have to see a doctor and make sure that they check you out, check out what your risk factors are before they put you on a medication. So, Avinity, there are some studies that show that it may increase the risk of what they call myocardial infarction, a stroke, or a heart attack. And so, if you have had those things in ever, or in the past year, you should really consider before you get put on those medications. So it really depends on like what is your heart health history. If you don't have any heart history and you're not at risk for it, then it's fine. But if you are someone who actually has some heart disease already, then it can kind of increase that risk. And we try to avoid prescribing Evenity for people who've had any of those three things, or those two things, having a stroke or having a heart attack or some really serious cardiac risk factors. So yes, not every medication is for everyone.
Okay, thank you. Going back to the DEXA bone scans, how often should a woman over 60 be scanned?
Well, I would say if you hit menopause and you're in that age of 50 to 65, I would at least get your first bone density. And then if you're over 60 and you have your bone density and say it's osteoporosis, you have to start treating it. Doing some exercise is not going to be enough. You're in that risk, you're at the risk category of having a hip fracture. So you have to do something about it. If you're on a medication or even not on a medication, you usually are getting screened every 2 years. So every 2 years is a good amount of time that you want to have that sort of screening test. Some people who are on medications, especially the anabolics, because they're still new, or newer compared to, 100-year-old bisphosphonates, we are maybe getting bone densities more frequently just to see, are we seeing those numbers start to come back up when you're on these medications? Because sometimes you can see the bone density actually increases on the DEXA scan over time when you're on a medication, say like teriparatide.
Gotcha. Thank you for that. I may mispronounce this, but hopefully you'll understand me on this one. What do you think about using the estradiol patch as part of a program to enhance bone density?
Oh, that's a good one. Well, I would say that, usually that one is going to be prescribed by your primary care doctor. Sometimes your gynecologist or OB-GYN might be following that along. It's not something that I would prescribe. But the evidence out there for those sort of hormone-based management of osteoporosis is actually pretty good. It shows that it does improve your bone density. But again, the strongest ones are the anabolic medication. So there's not a ton of research that's looking at how that impacts your arthritis or how that's going to impact you around having surgery or something along those lines. And of course, those also have their own risk factors too. So if you're thinking about getting on an estradiol patch or something along those lines to help your bone density, I would definitely follow up with your primary care doctor or whomever is prescribing that for you to manage your bone health.
Great. And what about collagen? Can taking collagen help rebuild bones?
So they do have a lot of supplements on the market, and you see them on the shelves, things that are collagen based that can help, and they perfect skin and nails and hair and your bones. So it's true that these sort of fibers are what your body is made of, but there's not a lot of good evidence that eating collagen goes towards the bones forming and turning over and having good density. So while in theory you would want to be able to eat something and it goes straight to the body part that you want to improve, but it doesn't always work out that way, unfortunately.
Okay, great. And how do you collaborate with other healthcare professionals, such as physiatrists and nutritionists, to provide comprehensive care for orthopedic patients?
So how do I collaborate with them? Well, typically if I have a patient who comes in to see me and they want to talk about their bone health, I will ask them first, who else are you seeing who's managing it? A lot of patients come in and they're on bisphosphonates and they've been on bisphosphonates for a long time. I've had some patients tell me that their primary care doesn't know much about the bisphosphonates because, unfortunately, in medical school, they tell us even when we start that your education in medical school has about a 4-year shelf life before there's new information that comes out. So every 4 years, it's like a whole new cycle of things to learn. So not everyone in the community as providers is offering these sort of newer medications that have come out in the past 15 years. And 15 years might seem like a long time, but not all providers are giving them. So I try to contact the primary care doctor or the rheumatologist or the endocrinologist if I know that a patient wants me to help to manage their bone health and try to collaborate with them to to see what they want to do, what their thoughts are on the particular medication and why they want, why they wanted Avinity, for example, or why they'd wanted alendronate, for example. And so I try to talk with them. And I think, coordinating care is always the best thing because, when you have 5 doctors and they're all doing and saying different things, it can be hard for a patient to figure out what's going on. So it's good to have your doctors on the same page. That's for sure.
Perfect. So we're approaching the end of our session. So I'll go through one more question, which I think falls a little in line with what we just talked about. The question is, when medical professionals provide conflicting diagnosis based off of the same test results, how should one proceed in making decisions about treatment?
Oh, well, that's a good one. So I guess for me, when I look at it as a medical provider, I would say it depends on what they're talking about. For example, if we're talking about, you're thinking you want to get on a particular medication and there's 2 different types of doctors. So a primary care doctor versus your endocrinologist, rheumatologist. If it's something that has to do with your bone health, then maybe the rheumatologist or endocrinologist will be the opinion to go with because they're the expert on that. If it has to do something with maybe getting treated with your bones right before you have an orthopedic surgery, and that's like my focus, then that's kind of the world where I'm living in. So it really depends on like what exactly is the conflicting diagnosis. Again, like I mentioned, some people just have different training and there's newer information coming out there. So what is the background and training of the people that you're looking at? I know that patients always come in and they tell me that they've done their research and they looked online or they Googled, they looked on Facebook, looked on different things, and it can be hard as a patient to know what to go to. You're in a chat room and people are talking about being on this for a long time, and it can be hard to decide. So I would say, you can kind of look to maybe what profession that people are coming from. You can look to what studies they might be referring to if they're saying that they think this is better for you. You can ask them for more information about why they think it's better. Any good doctor, which I'll be honest, being in Santa Barbara, I moved here last year in August. I'd say all the doctors I met with so far have been lovely and amazing. So they'd be happy to at least explain some of their rationale to you, why it is that they prefer one medication or another, or prefer you to get this procedure or another. So just ask your questions. Make sure when you see a doctor, if you come to see me, that you have a list of questions. It shouldn't be a chart that has 10 pages, but a list of your key questions to get answered. So that way you leave feeling satisfied that you have an understanding of why one thing is recommended over another. And you can make your comparison a little bit more clearly.
All right. Thank you so much. That was a wonderful Q&A session. And thank you everyone for your questions and for joining us this evening. Dr. Lomedico serves at 3 different locations for Alta Orthopedics. In Santa Barbara, she's at 510 Castillo Street, Suite 203. In Santa Maria at 2011 South Broadway, Suite N. And in Solvang, 2027 Village Lane, Suite 101. And again, this presentation is being recorded and you'll receive an email within the next week with a link to view the presentation and PowerPoint slides. A brief survey will appear after this webinar closes and we'd love to hear your thoughts. So thank you again for joining and have a happy and healthy rest of your evening. Thank you again, Doctor.
Thank you, everyone.